Hello, my name is Dr. Sherif Negm. I'm a professor of obstetrics and gynecology at Cairo University, and today we will be discussing malignant ovarian tumors. They are the third most common malignancies of all female genital tract organs after endometrial cancer and cervical cancer, but it is the most lethal of all of them, and we'll explain why a bit later. Most malignant ovarian tumors are epithelial in origin. Non-epithelial ovarian cancers are much less common. The majority of cases are discovered after the disease has already spread beyond the ovary with poor prognosis, and this is why they are more lethal than cervical and endometrial cancer, which usually present early with irregular vaginal bleeding and offensive vaginal discharge. They are classified mainly into epithelial, germ cell, and sex-cord stromal tumors. The malignant epithelial tumors include the serous cyst adenocarcinoma, mucinous adenocarcinoma, endometrioid adenocarcinoma, and undifferentiated adenocarcinomas. The malignant germ cell tumors include dysgerminomas, endodermal sinus tumor, choriocarcinoma, and solid teratomas, while the malignant sex-cord stromal tumors include the granulosa cell tumor and the Sertoli Leydig cell tumor. First, we'll talk about the epithelial ovarian cancer. Primary ovarian epithelial cancer is responsible for 60 to 70% of all ovarian tumors and 90% of all ovarian malignancies. Two-thirds of cases being first diagnosed very late at stage 3 when the treatment is less effective. It is usually associated with markedly elevated levels of cancer antigen 125 or CA125, which is considered an important tumor marker that correlates with the stage of disease, and more importantly, it is used for follow-up for prognostic factors. Most tumors are chemosensitive, showing good response to adjuvant chemotherapy after primary surgery. So why do primary ovarian cancers or epithelial ovarian cancers develop? There are several risk factors, but no definite etiology, of course. Reproductive factors such as nulliparity or infertile women are found to be more liable to develop ovarian cancers because of one theory behind this is that nulliparity or infertility results in a repeated ovulation, and the repeated ovulation results in repeated injury to the surface epithelium of the ovary. And of course, during pregnancy and lactation, ovulation and ovarian surface epithelial injury are markedly curtailed, thus theoretically having a protective effect against ovarian cancer. Hereditary or genetic factors are also very important in the incidence of ovarian epithelial cancers. 5 to 10% of epithelial ovarian cancers occur in women with hereditary predisposition, and in these cases they tend to occur at a younger age than in patients that do not have genetic factors. Hereditary predisposition is due to a defective gene in their families, which is a type of tumor suppressive gene, which is BRCA1 and BRCA2 gene mutation. There are three types of familial ovarian cancers are identified. The first is hereditary breast ovarian cancer syndrome, in which there is a genetic mutation in BRCA1 and BRCA2 genes. These are responsible for 75% of cases. There's also site-specific ovarian cancer syndrome, which only is responsible for familial incidence of ovarian cancer, and this is responsible for 15% of cases. And finally, hereditary non-polyposis colorectal cancer syndrome with endometrial breast and ovarian cancer. This occurs in about 10% of cases. So what are the risk factors for epithelial cancer? The first is age. It was found to occur with advanced age. This is usually occurs in women above the age of 59 in their sixth decade. And as we said before, nulliparity and infertility are also supposed to be risk factors. Demographic data or retrospective data has found that it is more common in white race than other races, although this may be biased by the type of research that was conducted, prior history of endometrial breast cancer, because if a patient had a previous history of endometrial breast cancer, she may have a metastatic disease in the ovary, or she may have a genetic predisposition making her more susceptible to ovarian cancer. And of course, family history of ovarian cancer is a very strong prognostic factor of high risk of ovarian cancer. So what is the pathology of primary epithelial ovarian cancer? Gross appearance, it may be solid, but most epithelial ovarian cancers tend to be a combination of both cystic and solid, having cystic and solid elements. Unilateral in the early stages, but later on as the tumor spreads, it becomes bilateral. So usually they start on one side in stage 1, and as the disease advances, they become bilateral. And the size is extremely variable depending on when the disease is discovered. And the substance of a tumor is a seed, of course, as any other rapidly growing tumor of extensive hemorrhage and necrosis. As you can see in this slide, this is the pathological appearance, markedly enlarged ovary. You can see in comparison the size of the ovary, the size of the adjacent fallopian tube, and is formed of an irregular mass, predominantly solid with central areas of cystic degeneration and areas of hemorrhage. Microscopically, there are usually adenocarcinomas in nature, and the histological type, they can be either serous cyst adenocarcinomas or mucinous cyst adenocarcinomas or endometrioid cyst adenocarcinomas, depending on the histological variety and depending on the degree of differentiation. And this is important because it has important prognostic value. They may be well differentiated, grade 1 tumors, moderately differentiated, which are grade 2 tumors, or completely undifferentiated tumors. Borderline epithelial tumors, that is, epithelial tumors with cellular features of malignancy but without invasion of the stroma, may occur in young women and usually have a better prognosis. The other type of tumor is the malignant germ cell tumors, and the incidence of germ cell tumors is only about 20 to 30% of all ovarian cancers, and they represent a smaller proportion, and 5% of germ cell tumors are malignant, and thus the majority of them are benign tumors. So what is the classification of malignant germ cell tumors? This germinomas, endodermal sinus tumor, choriocarcinoma, and malignant teratoma. They usually start de novo as malignant. Very rarely they start as benign and then they undergo malignant transformation. So what are the specific features of germ cell tumors that make them different than epithelial ovarian tumors? They usually occur in younger patients. They usually start in young age. And the commonest tumor, it is the commonest tumor in individuals who have abnormal gonads. So they're more common in patients with androgen insensitivity syndrome and gonadal dysgenesis, and also in sex chromatin negative females such as Turner's syndrome. They tend to grow rapidly, resulting in pelvic pain, and pressure symptoms usually occur earlier than in epithelial ovarian cancers, and as such, they may be diagnosed at an earlier stage than epithelial ovarian. Also, most tumors produce a substance in the circulation that can be used as a tumor marker, and this is very helpful in reaching a definitive diagnosis. This germinomas produce alkaline phosphatase and lactic acid dehydrogenase. Endodermal sinus tumors produce alpha-fetoprotein, and choriocarcinomas produce HCG. They're also radiation sensitive, and a chemotherapy is for some of them gives excellent results, especially in early cases such as stage 1A. And fertility-sparing surgery can be done if the disease is unilateral. You can do unilateral salpingophorectomy as a first line of treatment if the disease is confined to one ovary with an intact external capsule. First, we'll talk about this germinomas. These are the commonest malignant germ cell tumors, responsible for 30 to 40% of all malignant germ cell tumors. They represent 1 to 3% of all ovarian tumors, and they usually tend to occur at a young age, between the age of 10 and 30 years. And as we said earlier, most secrete alkaline phosphatase and lactic acid dehydrogenase, which can be used as a tumor marker and can also be used to follow up the success of treatment. In 5% of cases, occurs in patients with abnormal gonads, as in cases of gonadal dysgenesis or testicular feminization syndrome, as we said before. Pathologically, in gross appearance are usually solid ovarian tumors. The treatment in stage 1A, usually you can do unilateral salpingo oophorectomy as a form of fertility sparing procedure in young patients who have not completed their family or still wish to have uh, children, but you have to follow them up either with ultrasound or tumor markers to make sure that the disease is completely cured. And after they have completed their family, or in patients that do not want to have children or have completed their family, you may want to do a total abdominal hysterectomy and bilateral salpingo oophorectomy. Radiotherapy is also very effective in these tumors because, as we said before, they are radiosensitive. But if you're going to use radiotherapy in young patients, you have to bear in mind that the radiation therapy may destroy the contralateral ovary, and you may consider doing egg freezing, or if they are married, they can do embryo cryopreservation before starting treatment, or currently we can do even ovarian tissue cryopreservation until the end of the contralateral healthy ovary before starting radiotherapy. The endodermal sinus tumor. This is the second most common malignant germ cell tumor, and it is prevalent in young age, median age between 16 and 18 years. Most endodermal sinus tumors secrete alpha fetoprotein that can be used as a tumor marker. Pathologically, they are usually small solid tumors, which are almost always unilateral. Microscopically, they have a characteristic microscopic appearance, something known as a shielded duval body. These are cystic spaces in which project a glomerular structure with center vascular core. As you can see, a very characteristic appearance on this slide. The treatment, if it is still confined to an ovary, similar to this germinoma, you can do a unilateral salpingo oophorectomy. Chemotherapy, of course, is an option because the tumor is chemosensitive. And if it is unilateral, also consider conserving the contralateral ovary either by oocyte cryopreservation or by freezing of the contralateral healthy normal ovary before starting chemotherapy. Malignant teratomas are extremely rare. Of course, the much more common variety is the benign teratoma, which is the commonest germ cell tumor. The malignant teratomas, known as immature teratomas, these are malignant solid teratomas. They represent 1% of all ovarian teratomas, as we said, and usually occur in children under the age of 15 years of age. Macroscopically, they are usually unilateral solid tumors, and microscopically predominant of immature embryonic type of neural tissue with epithelial and mesenchymal tissue that may also be detected. Because it is so immature, it does not produce any tumor markers such as alpha-fetoprotein or HCG. Malignant transformation, benign cystic teratoma, this is very extremely rare. It predominantly, if it happens, it predominantly changes into a squamous cell carcinoma and usually occurs in postmenopausal women, but this is extremely rare. Choriocarcinomas are extremely rare also, and they usually produce an abundant amount of HCG, which can be used as a tumor marker. The malignant sex-cord stromal tumors, these are tumors that arise from the non-functioning or functioning stroma of the ovary. The functioning sex-cord stromal tumors include the estrogenic variety, such as the granulose cell tumor, or the androgenic variety, such as the Sertoli Leydig cell tumor. Both estrogenic and androgenic, as in case of gynandroblastoma, and these usually occur in abnormal gonads, such as in cases of undescended testes in androgen insensitivity syndrome. The non-functioning stroma very rarely occur, resulting in fibrosarcoma of the ovary. Of course, the functioning tumors will be given away by their hormones that they produce, so as estrogenic tumors will result in either precocious puberty if they develop in young girls, or postmenopausal bleeding in postmenopausal women in the menstruating or in the reproductive age women. They result most commonly in menstrual irregularities. Similarly, androgenic tumors would result in signs of hyperandrogenemia with hyperandrogenism and amenorrhea. First, we'll talk about the granulosa cell tumors. These are usually unilateral, solid, yellowish or yellow-gray in color. 75% are functioning, secreting estrogen, as we said before, and they may cause irregular bleeding or precocious puberty, as we just said before, if they occur in young girls, menstrual irregularities in menstruating women, or postmenopausal bleeding in menopausal ladies. That is why they can be detected early, not because we detect the tumor, but we detect the hyperestrogenic state that is produced by them. That it may be associated with endometrial cancer because of the unopposed effect of estrogen that cause hyperplasia of the endometrium in 5 to 10% of cases, and with endometrial hyperplasia in 25 to 50% of cases. So you can have either endometrial hyperplasia or cancer, endometrial cancer, depending on the duration of exposure to the unopposed estrogen produced by the granulosa cell tumors. And a tumor marker very importantly produced by this tumor is inhibin. So it can be used to detect or to confirm the diagnosis, and it can be also used as a tumor marker to detect the response to treatment, and of course to detect recurrence if it happens. Microscopically, the tumor is formed of granulosa cells arranged in different patterns. Cal-exna bodies are pathognomonic but are present in only 50% of cases. These are cystic spaces surrounded by granulosa cells arranged in a rosette-like appearance. Treatment, unilateral salpingio-oophorectomy, because the majority of them are slowly growing locally malignant tumors. Unilateral salpingio-oophorectomy is usually sufficient, but in postmenopausal women, total abdominal hysterectomy and bilateral salpingio-oophorectomy should be considered. There's no place for radiation or chemotherapy because they're not radio or chemo sensitive. So in young girls, consider unilateral salpingio-oophorectomy because the majority are unilateral and confined to the ovary. In postmenopausal women, total abdominal hysterectomy and bilateral salpingio-oophorectomy is more appropriate. Sertoli-Leydig cell tumors, these are extremely rare, representing less than 0.2% of all ovarian tumors. They are usually small, unilateral, solid tumors of low-grade malignancy. Many are functioning, producing androgens, and as such, they produce androgenic manifestations in the form of hirsutism and amenorrhea, and this may be the giveaway sign to their presence. And the treatment, if they are unilateral, you do unilateral salpingio-oophorectomy if a patient is young, or consider total abdominal hysterectomy and bilateral salpingio-oophorectomy in elderly patients. Metastatic ovarian cancer, secondary metastatic ovarian cancer forms about 5 to 6% of all ovarian tumors. The primary may be either from the genital organs, such as from the endometrium, cervix, tubes, or contralateral ovary, or extragenital tumors from the stomach, the colon, the breast, biliary tract, and the thyroid gland are very common primary sites of metastatic ovarian cancer. Pathologically, it is classified into two types: typical metastatic cancer, which resembles the primary cancer microscopically, or atypical metastatic cancer, what is known as the Krukenberg tumor. This slide shows secondary spread from endometrial cancer. You can see here endometrium with cancer inside it, and because of the lymphatic and vascular communication between the uterus and the ovary, it has spread to the ovary, and histologically the ovarian cancer here will be identical to that of the endometrium. Krukenberg tumors, 30 to 40% of metastatic cancers of the ovary are Krukenberg tumors. The primary is usually in the pylorus of the stomach, but less commonly in the colon, breast, or biliary tract. There are bilateral solid tumors, as you can see from this slide, and retaining the shape of the ovary. You can see from this slide, this is the bisected uterus here, and you can see in comparison the size of the uterus with a huge bilateral solid ovaries, which retain the appearance of the ovary but are solid masses 5 to 6 times greater than the size of the ovary. The main interest is in its histiogenesis, and the most acceptable theory is that the malignant cells reach both ovaries by retrograde lymphatic spread. Of course, the prognosis, as in all metastatic tumors, the prognosis is usually very bad, and most patients die within 1 year because most of the lesions are not discovered until the primary disease is advanced. What is the pattern of spread of ovarian cancer? The primary method of spread of ovarian cancers are either, like most other cancers, direct extension, lymphatic spread to the para-aortic lymph nodes, transcelomic spread, that is extrafoliation of the tumor cells into the peritoneal cavity. That means this happens as a result of rupture of the capsule and spread into the peritoneal cavity, or hematogenous spread late and rare. This usually occurs to distant sites such as the breast, the lungs, or the liver. So what is the clinical picture of primary malignant ovarian cancer? It is the disease of the late decade, as we said at the beginning, usually occurring between 55 and 65 years of age in the majority of cases. Symptoms in the early stage of disease, most cases are asymptomatic, but sometimes patients may give some non-specific symptoms, especially upper and lower gastrointestinal symptoms, such as dyspepsia, indigestion, and anorexia. As the tumor enlarges and causes pressure on the adjoining structures, it may cause pressure symptoms on the urinary bladder, resulting in urinary frequency, or pressure on the rectum and the sigmoid colon, resulting in constipation with or without pelvic pain. As the tumor advances in late stages, and this is the usual presentation, there is abdominal pain and cachexia because of the large size of the tumor, and sensation of abdominal enlargement. There's abnormal uterine bleeding, and especially postmenopausal bleeding, and rarely ascites may be the first clinical presentation. On examination, the most important physical sign is the palpation of a pelvic mass, and usually this mass is discovered during routine gynecological exam because, as we said, most cases are diagnosed late after they have reached stage 3 rather than very early in stage 1. In late cases, a pelvic abdominal fixed solid mass can be felt. Bilateral solid fixed masses are always suspicious of malignant ovarian tumors. So what are the clinical features that suggest to us that the patient may have a malignant ovarian tumor? From the history, it, as we said before, it usually has, in the extremes of age, before puberty, suspect germ cell tumors, or above the age of 40 to 60, then suspect epithelial tumors. Rapid growth of the tumor is always suspicious. Pain and rapid weight loss are always late symptoms. Tumors discovered in women with family history of breast, colonic, or ovarian cancer. Postmenopausal bleeding is always a harbinger of malignancy. It may be either endometrial or ovarian cancer, and symptoms of viralizations are suspicious of sex-cord stromal tumor. On examination, there's usually malignant cachexia with marked and rapid weight loss and dehydration. There's a palpable supraclavicular lymph node, which is known especially on the left side, which is the Virchow gland. Pleural effusion, however, it may be present also in benign conditions such as an ovarian fibroma, resulting in what is known as the Megg syndrome. There may be an associated breast mass or on breast examination, suggesting that the primary is in the breast and the ovarian mass is a metastatic spread from the breast cancer. Sometimes there's unilateral leg edema resulting from unilateral pressure by the tumor with venous and lymphatic obstruction. So if you have unilateral edema of one lower limb, then this is usually an ominous sign suggesting that some sort of local lesion is causing compression on the veins and lymphatics on this side, as opposed to bilateral leg edema, which may be due to systemic causes such as heart failure or hypoproteinemia or liver cell failure. Abdominal examination. On inspection, the abdomen is usually enlarged, but this is usually in advanced cases, as we said before. The overlying skin showing peu d'orange characterization, pitting edema. On palpation, the tumor has a characteristic appearance. It is usually solid, fixed, especially if it is bilateral. On percussion, if you have ascites, then you'll have shifting dullness, but sometimes ascites, as we said before, may be associated with benign conditions such as Megg syndrome and ovarian fibroma. Pelvic examination, nodules may be palpated in Douglas pouch in the presence of non-tender adnexal masses, because if you have a tender adnexal mass, then it most probably is a benign condition such as an endometrioma. or an inflammatory mass. But if it's non-tender, then it may be more suspicious. Bilaterality, especially if solid and neck cell masses, these are very presumptive of malignancy, especially, of course, if they're also fixed masses and if they are amalgamated with pelvic organs resulting in a frozen pelvis. This is also highly suspicious, but bear in mind that some benign condition may result in a frozen pelvis, such as chronic pelvic inflammatory disease and advanced stages of endometriosis. At laparotomy, the suspicious findings are malignant ascites, which is usually acidic fluid that is blood stained, bilaterality, by presence of bilateral tumors that are fixed to the surroundings and invading the capsules are always highly suggestive that the lesion is malignant. The presence of extracystic papillae and adhesions to the surrounding structures is also a very characteristic feature. Peritoneal nodules or secondary deposits in the omentum, intestine, or liver. These are characteristic findings of advanced stage disease, stage 4. It's usually associated with these findings. The visible consistency with a cut section of the tumor showing hemorrhage and, variable consistency with a cut section of the tumor showing hemorrhage and necrosis. So if you're not certain, you can do a frozen section while doing the laparotomy, and the pathologist may examine the tumor grossly and microscopically to confirm whether or not it is malignant. We don't usually just rely on clinical history and examination, but nowadays we rely on special investigations, and the most important of them is pelvic ultrasound, chest X-ray, CT and MRI, upper and lower gastrointestinal endoscopy, these are and IVP. And the aim of these investigations is first to confirm the diagnosis that this actually is an ovarian tumor and that is most likely malignant. And the second is to try and determine its spread, whether it is confined to the ovary or if it has spread outside. That's why we do a chest X-ray. And thirdly, to try and detect a primary, to try and determine whether the ovarian tumor is a primary ovarian tumor or secondary from spread to other sites. That is why we do an upper and lower gastrointestinal endoscopy to try and detect primaries in the pylorus or in the colon. Paracentesis may be of value in advanced cases presenting with ascites or pleural effusion, but care has to be taken when doing paracentesis in these patients because they may open a malignant tract to the skin, so it is usually not considered a very important investigation, especially with ultrasound determining the presence of ascites and tumor markers also helping us to confirm the diagnosis. Endometrial curettage, it can be done in cases of vaginal bleeding. If you suspect that the patient has a thick endometrium, then endometrial curettage and finding of endometrial cancer may help in the diagnosis. And of course, IVP is important to determine if there is compression of the ureters and back pressure on the kidneys, and this may be helpful to the surgeons at the time of surgery to help them avoid damaging or injuring the ureters. The tumor markers such as cancer antigen 125, the normal value is usually less than 35 units per milliliter, and it is markedly elevated in epithelial ovarian cancer, usually over 1000 milliunits. However, it may be elevated in some benign condition, although not as high as in cases of epithelial ovarian cancer. It may be also elevated in endometriosis and chocolate cyst, but the levels is usually not in the thousands, usually below 100, sometimes maybe 100 or 200. It is also important in monitoring the response to chemotherapy. As we said before, the tumor markers are not as important in diagnosing the condition as it is in following up the response. Because if you have a tumor marker going down after treatment, then this indicates that the treatment is successful and there is no recurrence. But if the tumor markers CM25 starts to go up again after treatment, this may indicate that there is reactivation and starting spread once again of the disease. Other tumor markers, depending on the kind of tumor, serum beta HCG is elevated, of course, in choriocarcinomas, alpha-fetoprotein and endodermal cutaneous tumor serum alpha alkaline phosphatase and lactic acid dehydrogenase and dysgerminoma, and serum inhibin, of course, as we said before, is elevated in cases of granulosa cell tumors. Screening programs for ovarian cancer have been advocated by some groups, which involves routine yearly pelvic examination in postmenopausal and perimenopausal women, and periodic transvaginal ultrasound coupled with serum COM25 in those with an enlarged ovary. These screening programs have been found in many Western countries not to be very cost effective, and are preserved mainly for patients who are at high risk of having ovarian cancer, such as those with a strong family history or previous history of breast or endometrial cancer. Differential diagnosis of ovarian masses, other pelvic masses such as any adnexal mass such as hydrosalpinx or endometrioma, uterine enlargement such as myomas and pregnancy, of course, colonic masses, retroperitoneal masses such as a pelvic kidney and retroperitoneal sarcoma, abdominal masses such as liver or pancreatic tumors and tensocytes. Of course, this differential diagnosis can be all excluded by abdominal and pelvic ultrasound, CT and MRI will help to confirm that this is actually an ovarian malignancy rather than any of these possible other causes of abdominal enlargement. The mainstay of diagnosis and treatment of epithelial ovarian cancer is something known as exploratory laparotomy in ovarian cancer. This is the final diagnosis, and because, as we said before, the final diagnosis can only be made at the time of exploratory laparotomy, which will serve not only for diagnosis but also for surgical staging and primary surgical treatment. The surgical staging of primary ovarian cancer or the exploratory laparotomy will involve certain set rules or a certain methodology. The surgical staging, as we said, it is the only standard method for staging because clinical staging is insufficient. The first step is to do a large midline subumbilical exploratory incision that may extend up above the umbilicus, and we do a midline incision because it affords better exposure of the intra-abdominal and pelvic organs rather than a transverse suprapubic or phalangeal incision. Next, we have to explore the pelvic and peritoneal cavity to detect the presence of any nodules or spread outside the pelvis. If there's any fluid in the pelvis, we have to aspirate it, the acidic fluid, or if there's no fluid, then we do peritoneal washing with saline and then aspirate that fluid and send it for cytology. Next, we look at the omentum to see if there are any omental nodules. If not, then we do an infracolic omentectomy and send it for pathological examination. The pelvic and para-aortic lymph nodes are also sampled, and any large lymph nodes have to be removed and sent for pathology. And then you have to resect of any enlarged nodules or masses. Finally, we have to do a total abdominal hysterectomy and a bilateral salpingio-oophorectomy. Of course, this procedure, as you can see, is a very advanced and extensive procedure and should only be carried out by an expert gynecological oncologist surgeon who has done this procedure before and is very familiar with doing a resection anastomosis of the small intestinal loops, pelvic accentration, and colostomy, because he may be required to do any of these procedures at the time of the primary surgery. The complete procedure, as we said before, will then be a total abdominal hysterectomy or debulking of the malignant tumor, omentectomy, lymph node sampling or resection, removal of any pelvic or extrapelvic tumor masses, and cytology of the peritoneal fluid. The most important thing, as I said before, is that this procedure should be done by an expert gynecological oncologist, and his main aim is something known as primary cytoreductive surgery, that is removal of as much of the tumor tissue as possible, with resection if necessary of any small or large bowel, sometimes they have to do anterior or posterior pelvic excenteration, because the prognosis of the patient depends primarily on the results of the primary cytoreductive surgery. If the primary cytoreductive surgery is done well and the residual malignant tissue in the pelvis is minimal, then the patient has a good chance of responding to subsequent chemotherapy. However, if the surgery is done by someone who is not experiencing gynecological oncology, and he just does a simple total abdominal hysterectomy and bilateral salpingophorectomy and leaves the rest of the malignant tissue in the pelvis, then these patients fare very badly and have a very, very poor survival rate. This is the FIGO surgical staging of primary epithelial ovarian cancer. The stage 1 tumors, these are tumors that are limited to the ovaries. Stage 1A, these are growth limited to one ovary with no ascites and no tumor on the external surface with an intact capsule. These are usually the best tumors, and patients are considered extremely lucky if they're diagnosed in this very early stage, because the majority usually do not have symptoms at stage 1A. 1B is growth limited to both ovaries but with no ascites and no tumor on the external surface with an intact capsule. So similar to stage 1 but with spread to the contralateral ovary. Stage 1C, in which the growth is also involving one or both ovaries with pelvic extension. In this case, there is some pelvic extension. So if it is either to the uterus or the tubes or other pelvic structures. This is known as stage 1C. Stages 2A and 2B with tumor on the surface of one or both ovaries, with capsule ruptured or the presence of ascites containing malignant cells or positive peritoneal washing. So this is the appearance of stage 1A and 1B and 1C. 1A is a tumor limited to one ovary with no ascites. 1B limited to both ovaries with no ascites, and 1C ascites or positive peritoneal washing are also present. And as you can see, the treatment varies greatly between these three stages. Stage 1A and B can be treated by surgery alone, while if you have spread outside of the capsules, then you have to add chemotherapy. This is stage 2, growth involving one or both ovaries with pelvic extension 2, as we said before. 2A, the uterus and all the tubes. 2B, other pelvic tissues. And stage 2C, which is stage 2A or 2B with tumor on the surface of one or both ovaries, or the capsule has been ruptured, or the presence of ascites containing malignant cells or positive peritoneal washing. So here you can see that the tumor has spread outside the ovary, and the prognosis has deteriorated markedly, and treatment, of course, in these cases will require both surgery as well as chemotherapy. How about stage 3? The tumor has spread further, in which the growth is involving one or both ovaries with peritoneal implants outside the pelvis or positive retroperitoneum or inguinal lymph nodes. Stage 3A, the tumor grossly limited to the true pelvis but with negative nodes, or 3B, tumor with implants that are less than 2 centimeters on the abdominal peritoneal surfaces with negative nodes, or tumor stage 3C, in which there is tumor of implants that are greater than 2 centimeters with no lymph nodes and positive pelvic lymph nodes. And superficial liver metastasis is also included in stage 3. So in stage 3, the growth has spread, but its spread is mainly maintained inside the pelvis with positive retroperitoneal or inguinal nodes. Stage 4 is spread to distant structures, and here it can spread either to the liver or to the lung or to the brain. If pleural effusion is present, there must be positive cytology to allot a case as stage 4 because it may be due to lymphatic obstruction. Parenchymal liver metastasis also equals stage 4 as opposed to superficial liver metastasis, which was considered to be stage 3C. So what is the surgical treatment of ovarian cancer? Fertility-sparing surgery in special cases. You can do unilateral salpingio-oophorectomy. As I said before, this may be done only in cases of stage 1A disease, tumor confined to one ovary with an intact capsule and negative peritoneal cytology. This is done in a young patient who still needs her fertility. Such conditions are mostly met with in some early epithelial tumors, such as borderline malignancies, but more commonly with malignant germ cell tumors such as dysgermanomas and endodermal sinus tumors, which tend to occur in young women, and malignant sex chromosomal tumors such as granulosa and sertoli Leydig cell tumors. So these are the tumors that are most likely to be managed by fertility-sparing surgery in the form of unilateral salpingio-oophorectomy. Advanced stage cancer requires both surgery as well as chemotherapy. The surgery is known as primary cytoreductive surgery or debulking, and as we said before, the main aim is removal of all primary cancer and, if possible, all metastatic disease, leaving a residual tumor mass less than 1 centimeter in diameter. Because this has a much better prognostic value, and the patients, if they have a small residual tumor mass, they respond much better to secondary chemotherapy. And interval debulking is, if the primary debulking is not feasible, then chemotherapy is done first to try and shrink the tumor a little bit before doing surgery to allow for subsequent more complete radical surgery. But most surgeons prefer doing a primary cytoreductive surgery before starting chemotherapy, because if you do chemotherapy first, many have found that this increases the incidence of adhesions at the time of surgery. Second look surgery in ovarian cancer. Nowadays, you don't have to do that. We can rely on modern imaging techniques such as spiral CT and MRI, together with follow-up with serum CA25, have largely nullified the need for second look surgery. But at the present state, it's only places when a tumor marker is raised apart from negative imaging for tumor residues. How about chemotherapy? Of course, chemotherapy has a great place for treatment in ovarian cancer, except for stage 1A. Chemotherapy, of course, whether it's a single or multiple agent, has a major role in the management of ovarian cancer, especially in advanced disease, and mostly with epithelial ovarian cancer. In earlier stage disease, only with poor prognostic factors such as poorly differentiated tumors, ruptured capsule, or positive peritoneal washes. Not really in stage 1A except in 1C. 1A and 1B usually do not need chemotherapy, but stages more advanced in stage 1A and 1B may require and respond well to chemotherapy. Advanced stage disease, chemotherapy is a mainstay in all cases, from stage 2 up to stage 4. All cases after primary debulking surgery. Sometimes it can be given, as we said before, as a new adjuvant chemotherapy before doing interval debulking. Before doing the surgery, we may give chemotherapy to shrink the tumor a little bit, make it more manageable at the time of surgery. Or the third line is palliative therapy in patients with irresectable tumors or patients with recurrent disease. And here the main role of chemotherapy is to improve the quality of life of these terminally ill patients, such as in patients that have tumors that are causing intestinal obstruction or some site of pressure on the bladder or bowel or the renal pelvis. If you give them adjuvant chemotherapy, the tumor will shrink, and this will improve their quality of life, but will not ultimately increase their lifespan or affect the overall prognosis. And the types of chemotherapy used, usually 6 cycles at 3 to 4 weekly interval, and most frequently used chemotherapeutic agents are cisplatin or carboplatinum, alone or in combination with paclitaxel. These are the most commonly used drugs or drug combination in the treatment of ovarian cancer. Radiation therapy has very little role in epithelial ovarian cancer, but may be used as an adjuvant therapy following cytoreductive therapy in patients who refuse or are not good candidates for chemotherapy. There are 2 forms that may be used either intraperitoneal radioactive colloids or whole external beam abdominal irradiation, but in general they are not very effective and are commonly not used in epithelial ovarian cancer. Of course, the prognosis of ovarian cancer will depend upon the histological type of ovarian cancer, epithelial or non-epithelial ovarian cancer. And the most important thing, of course, is the stage of ovarian malignancy at which it is diagnosed. The best prognosis, of course, is in stage 1A. And the type of surgery performed, as we said before, optimal versus suboptimal surgery. So if the surgery, the primary cytoreductive surgery was done by a competent gynecological oncologist, the patient will have a much better outcome and prognosis than if it is done by a general gynecologist who does a simple hysterectomy. Histology and grading of a tumor are also related to the prognosis. Of course, if you have a very well differentiated tumor, this has a better prognosis and it's usually more slowly growing, and it may be more responsive to chemotherapy, while poorly differentiated and clear cell carcinomas usually have a much worse prognosis. And of course, whether or not the tumor is responsive to chemotherapy also is a very important factor, because chemotherapy, as we said before, is used effectively in all stages of ovarian cancer other than stage 1A and 1B. The 5-year survival rate in epithelial ovarian cancer, of course, depends upon the stage. In stage 1, it is between 85 and 90%. As the stage advances, as you can see, the 5-year survival rate falls dramatically. In stage 2, it is 80%, but as the tumor spreads outside the ovary into the pelvis, in stage 3, it falls to 15 to 20%, and it spreads to distant organ. The 5-year survival rate is about 5% only. Thank you very much for your attention.